Thanks. I guess I need to use this. It's not too loud. Okay. And hopefully they can hear me wherever they're watching from. So today I'm going to talk to you guys about disruptive mood dysregulation disorder. It's a new disorder in the DSM-5. I want to preface this whole talk by letting you know that I am not one of the foremost experts in the field on this. There are very few of those. This is very new. So my goal today is to give you all an introduction to what this is, give you some of the rationale for where it came from, and start to guide you towards how to understand this disorder and how to consider treatment when you're seeing kids who fit this profile. So disruptive mood dysregulation disorder came about because in the 90s they started talking about this group of kids they had who were chronically irritable. And there were these psychiatrists and pediatricians and psychologists who started to talk, and they were like, well, you know, our adult bipolar patients are irritable sometimes, and so maybe these young kids who are chronically irritable are just young bipolar patients. And so it started to be conceptualized that way, and what we saw was a drastic, over 500% increase in the rates of diagnosis of pediatric bipolar disorder. And then all of a sudden, around 2000, they started to say, whoa, we got to hit the brakes on this. Like, what's going on? Why are we having such a dramatic increase in the rate of bipolar disorder amongst children? And so they tried to figure that out and tried to find a responsible way of characterizing these kids who have this chronic irritability. And they started to say, maybe it's not bipolar disorder. So I want to give you kind of some background on what the DSM-5 criteria is. So disruptive mood dysregulation disorder refers to recurrent temper outbursts that are grossly out of proportion to the situation. We're not talking about your standard temper tantrum. We're talking about these kids are punching walls, throwing things because they spilled their milk. These are big-time overreactions in these situations. And these outbursts are occurring at least 3 times a week, and they're inconsistent with the developmental age. This is not diagnosed before age 6, because before age 6, temper tantrums are fairly normative. Most kids have temper tantrums. And so we're looking for it to be developmentally inconsistent. The other thing is, and this is the kicker, is that in between these temper outbursts, these kids with disruptive mood dysregulation disorder are persistently irritable. So we're seeing them stay irritable in between these temper tantrums. The symptoms have to be present for at least 12 months. They have to occur in 2 or more settings, and it has to be severe in at least one of those settings. And it's only diagnosed between 6 to 18 years of age. Once you're an adult, you can't. This diagnosis no longer applies. And it has to have an age of onset before 10. You don't have to catch them before they're 10, but you have to have evidence of a diagnosis of a disorder before age 10. Now, some of the interesting things here are, if a kid has a history of mania or hypomania, if you have evidence of a manic episode, the kid doesn't get disruptive mood dysregulation disorder, it gets a bipolar disorder. And kids who have disruptive mood dysregulation, I'm going to call it DMDD. If kids have DMDD, they can still go on to have a manic episode and be diagnosed with bipolar, but I'm going to talk a little bit about those differences in a minute. But it can't be diagnosed at the same time. You can't have comorbid DMDD and bipolar disorder at the same time. At the same time, it also can't be diagnosed with ODD. So it's either DMDD or ODD. We'll talk about why that's problematic in a little bit. And you also can't diagnose it at the same time as intermittent explosive disorder. Although a lot of kids, and one of the things that I've read is that there are a lot of kids who will eventually be diagnosed with DMDD, who you will initially diagnose with intermittent explosive disorder because they haven't met that 12-month persistently irritable threshold yet. They've only been persistently irritable for 9 months, so they don't meet criteria, but they have a lot of these symptoms that are consistent. And so you start with one and then move to the other. All right. So the other thing I want to let you know is, please feel free to ask questions as I go. If you have a question, shoot your hand up. I'm happy to answer it to the best of my ability. But I want to I put this slide in here because I want to focus on this part a little bit, because I think that when this diagnosis first came out, there was this, oh, it's just another diagnosis, it's just a fake diagnosis, where did this come from, it's a bunch of BS, like why are we talking about this, it's just childhood bipolar, it's, you know, whatever. And I want to argue in the next few minutes that there is something here. This is a legitimate attempt to capture something that people were noticing clinically. And I think that there's a good reason to identify these kids as different, at least to look at it for a while to see if there is a different way of treating these kids. Because I think part of the frustration was a lot of providers were feeling like these kids were not adequately treated, and they were struggling to find success in treating these cases. So the biggest thing is, and I'll say this time and time again, DMDD is not pediatric bipolar disorder. It is not. They're different disorders. And we have evidence that they're different disorders. For bipolar disorder, we see mania. We see kids, we see people who have manic episodes. They cycle between being manic, being euthymic, and being depressed. They go through those things in episodes. We don't have any evidence that bipolar disorder in kids looks any different than it does in adults. We see it coming in those, you have a manic episode and then you come down off the manic episode into a depressive episode, and then sometimes you level out for a while. We see that pattern occurring with kids who have bipolar disorder. Kids with DMDD, we see a different pattern. We see them sit with this low level of irritability for much of the time. They have this chronic irritability, and then periodically they have these temper outbursts multiple times a week where you're seeing this big presentation of aggression or anger, but not overall inconsistent with their day-to-day presentation. And we're not seeing these kids go up and be euthymic most of the day. These kids are not just, oh, they do good most days and then something happens and they get set off. No, these kids are irritable most of the time. This kid, you can tell you're walking on eggshells around him because you never know what's going to set him off. There aren't necessarily good days and bad days with these kids. There's mostly bad days or worse days. The other thing is they did some research and they looked at kids who have DMDD and kids who have met the diagnosis based on the DSM-5 criteria, and then they looked at their parents. And they brought their parents and they did an assessment with their parents. And what they found is when they look at kids who have DMDD, only 2.5% of their parents have bipolar disorder. But when they look at kids who are diagnosed with pediatric bipolar using strict criteria, 30% of their parents have bipolar disorder. And I want to argue that that's a difference. There's something going on there. We know that bipolar disorder is highly genetic and highly heritable. And this is something different. This is not pediatric bipolar disorder. We're capturing something different here. The other thing is they've done some, and so I'm going to get into this a little bit. So they've been looking at this for a while. They've been looking at this, this mood dysregulation for a while. They've been calling it something different. They've been calling it severe mood dysregulation disorder before DSM-5 came out, and that's how they use the research criteria, which is a little different than DMDD. But they tracked some of these kids who were diagnosed with this chronic irritability who didn't have bipolar disorder, and they tracked them long-term to see what happened long-term for these kids. Where did they go? What happened to them? And what they found is these kids who have DMDD, well, what they found is, first of all, kids with bipolar disorder, young kids with bipolar disorder, grow up to be big kids with bipolar disorder, right? However, young kids with DMDD, with these temper tantrums, don't grow into big kids with bipolar disorder. What happens is these kids with DMDD grow up to be anxious and depressed adults. And so the trajectory of these kids that we've captured with this new diagnosis, we're getting something different here. We're not getting this pediatric bipolar. These kids with this chronic, persistent irritability, there's something else going on here. And so why does it matter? Like, why do we care that we've captured this? What's important about it? And I think one of the first things is the treatments for bipolar disorder, there are a lot of side effects associated with those medications. a lot of adults in bipolar disorder are put on mood stabilizers, including lithium, and it's got incredibly high toxicity, right? That's a really risky medication to use. We don't want 6, 7, 8-year-olds on that medication unless it's absolutely necessary, and we have some pretty clear indications that it's going to help them out long term. And so far what we have is we have one RCT done on kids with severe mood dysregulation disorder, and I'm going to talk about how that's different from DMDD in a minute, and there wasn't any benefit. And that's only one study. It's only initial, but so the initial stuff is showing us that that medication is not necessarily helpful for these kids. The other thing is, yes? For that RCT? That RCT was lithium. They've done some other stuff with other mood stabilizers with varying success, but it's been mostly case study. So there are some studies I saw that were 5 or 6 patients, and they tracked, and they actually did see some success, but there hasn't been an RCT with kids with these meeting this diagnostic criteria. Yeah. The other thing is that 48% of children diagnosed with pediatric bipolar are prescribed an antipsychotic medication. And I think most of you probably know there are a lot of side effects associated with those medications. Those are not things that hopefully not things that psychiatrists prescribe lightly to children, right? And so there was concern like, okay, we have this drastic increase in pediatric bipolar disorder. We're giving them these kind of scary medications. We want to make sure this is a thing. And we need to be careful about distinguishing between these two things, because if we're characterizing these kids with this chronic irritability as bipolar, then we're putting them at risk for all the side effects of those medications, potentially very unnecessarily. One of the other things that we know is that psychiatrists are often cautious to prescribe SSRIs and stimulants to bipolar patients because of risks of triggering a manic episode. The only problem is if you don't have bipolar and you don't have a history of manic episodes, there's no risk of triggering a manic episode. And it's an important consideration to make, because stimulants for kids who have comorbid ADHD with DMDD, there's some evidence to suggest that there is an effect and a benefit of stimulant medication for these kids. Again, I'm not a psychiatrist, so I'm not telling you, go advocate for these things, but I encourage you to consider a lot of these things, and this is the information that's out there, and I'm happy to share any of these citations with any of you, because I think it's often ignored that some of these first-line psychiatric medications are not considered for these kids because they think it's youth bipolar. They think it's pediatric bipolar. The other thing that they're often not doing is the SSRIs, which if we think about these kids as moving on a trajectory from DMDD to later depression and anxiety, SSRI would be indicated. That's what we would give an adult with depression or anxiety. And if it's not being considered here, then it's potentially problematic. But I want to also caution us on making interpretations from this information, from DMDD, because it is new. And it's not without its own set of problems. So the DMDD research is based on severe mood dysregulation, based on a diagnosis called severe mood dysregulation, which psychologist Dr. Liebenluft developed and kind of identified to capture these kids before the DSM-5 came out, and it was kind of the initial research that the DSM-5 is based on. But there's some significant differences between what she was using as her diagnostic criteria and what eventually came out to be DMDD. Originally in the research, she was looking at things like chronic irritability, she was looking at the temper outbursts 3 or more times a week, but she was also identifying kids who had hyperarousal symptoms. She was looking at part of the diagnostic criteria she used was that these kids were having some of these almost hypomanic symptoms. And so there's further confusion in how to interpret some of the early research that was done using that diagnosis to make generalizations to the DMDD diagnosis that we have currently. And I think that some of that research is really good, and I think that even with the SMD research, they were finding that that group that had that very low level of hyperarousal symptoms was still different than pediatric bipolar. Those kids were still not growing up into having adult bipolar disorder. The other thing is there's no real agreed upon measure. You know, if you think a kid has autism, you might give him the ADOS. If you think a kid has ADHD, you give him the Connors or the Vanderbilt. We have assessments for those. We have kind of gold standards, things that have been practiced, tried and true. For DMDD, we don't have anything. We don't even really have an agreed upon way to define irritability amongst kids. Is it just when they lose their temper? Do they have to be resentful? Do they have to have a sour look on their face? Do they have to fight with other people? I mean, what does it look like? And different people define it in different ways. And so part of the problem is we don't have a unified definition. We're not looking at irritability all the same way. And it creates problems with how reliably we're identifying this diagnosis. It's brand new. People, for as much criticism as people gave it, people have not been shy about giving the diagnosis to kids. And there are some problems because what we're seeing is that in inpatient settings, there's only about a 50% agreement between different providers about whether or not a kid meets criteria for DMDD. So if you ask me and you ask Dustin and we see in the same kid in an inpatient setting, only half the time we're going to agree that this kid has DMDD. It gets even worse if we're working in an outpatient clinic. Only 1 out of 20 times are we going to agree that this is, 1 out of 10 times are we going to agree that this kid has DMDD. And so I think there's some work to be done on how we assess these kids. But again, I want to emphasize that there's evidence that once we've carefully identified these kids, we are capturing a subset of the population that is different and does not have pediatric bipolar disorder. We just have to get better about it. The other thing is, and the other reason that I think is an argument that it's not pediatric bipolar disorder is there's inconsistent stability. So these kids, if you assess them today and you assess them a year from today, they may well not meet criteria for DMDD anymore. In fact, only 19% of kids who are assessed a year later still meet criteria for the diagnosis. And so I think there's some legitimate questions out there about why that is. Why is this diagnosis not stable over time? What's happening? Is this just something that is less pervasive, or what's going on here? But I think that's a question that needs to be answered. Or does that have to do with just our difficulty in diagnosing this disorder because we don't have a clear-cut way of doing it at this point? So I talked about this at first, but some important considerations when considering a case that you think has DMDD. If you have a kid, you're like, okay, he's pretty irritable, he's got some pretty big tantrums, mom's complaining about it, his mood's all over the place. It's important to understand that 85% of kids under the age of 5 have tantrums. I mean, it's perfectly normal behavior. And so you really need to consider if you have a kid on your caseload or you're seeing a kid for the first time and they have this diagnosis, if they're under the age of 5, they shouldn't. It's inappropriate. You shouldn't be diagnosed before age 6, right? And if they're 7 or 8 and mom says, yeah, he used to have really, really bad tantrums, well, when? If he was having them before age 5, okay, they could still be indicative of DMDD, but you also have to consider they're also potentially normative. Just because a kid was having some level of tantrums before age 5 doesn't mean they have DMDD. They need to be severe and out of proportion for the situation. The tantrums are severe and chronic. The other thing, and this is another, so not everybody's on board with DMDD, and I wouldn't say that I'm even fully on board with it. I think there's something there. I don't know if we've fully captured it yet. But DMDD frequently co-occurs with ADHD and ODD. You rarely see a kid who has DMDD who doesn't also have ADHD or ODD or both. And so there's a hypothesis out there by John Lockman, who says that he's proposing that it actually what we're capturing here is a subset of ODD, and that there are 2 subsets of ODD. And we have this irritable subset of ODD that grows up and becomes our conduct disorder that are more or less typical like ADHD, ODD, conduct disorder, antisocial personality disorder kind of trajectory that we see sometimes. And then we have this other group of kids who we're diagnosing with ODD and they later grow up to have depression and anxiety. And that those are 2 distinct subtypes of ODD. There's not a ton of evidence out there, but hopefully that's something that's going to be researched. Yes. You'll see that, but that's not necessarily a diagnostic requirement for them to be well behaved in one setting. Yeah, yeah, and I think with these kids you wouldn't see that. You'd be. I think what I would argue is, based on the descriptors for these kids, you need it in 2 or more settings, and it needs to be severe in one. And from the descriptions I've heard from some of the researchers who work with these kids on a day-to-day basis and have done presentations on it, they talk about these kids as you can just kind of see the look on these kids' face. They look irritable. You walk into a room and you can tell you need to kind of be, you need to be careful with your words because you might set them off. And so I also have my own personal hypothesis with no evidence to back it up, but I'm going to share it with you guys. Because there's some studies done in 2014, and they looked at the risk factors for developing DMDD. And what they said was, if the family has a history of parental substance use or low parental support or parental hostility, there's a higher likelihood of a kid developing DMDD. Well, to me, that sounds a lot like the Adverse Childhood Experience Survey and some of these adverse childhood experiences that these kids are being exposed to. And I've yet to see a study that looked at and ruled out and did a differential between this and PTSD and some of the trauma-related things. And the presentation that we're hearing about from these kids is pretty consistent with what we see with some of our severely abused and neglected kids. And I think that we see this diagnosis more frequently in those kids. Just in my own personal experience, I've seen this diagnosis used more often among those kids. Whether or not I feel like it's accurate, it's still being used to capture those kids. And so I'm wondering whether or not those early childhood experiences are contributing to different brain development, and they're having difficulties in regulating emotions and in inhibiting some of these responses that's contributing to this difficulty. And in fact, there's some evidence to suggest that there are differential brain structures between children with pediatric bipolar disorder and with DMDD to show that these kids have a hyper-arousal in their emotion systems in their brain and under-arousal in their inhibition systems, which we also sometimes see with kids who are exposed to trauma. And so don't quote me on that. I guess you could, but don't fully believe it. Just think about it as a possibility, and hopefully they're going to come out with research on that. I imagine I see it going that way, at least considering it and ruling it out, and maybe they do. So, in summary, I went faster than I thought I was going to. I left lots of time for questions. But part of it is, I want to caution you, it's a new diagnosis. This is something that it's just come out. The research we have right now is based on really a slightly different diagnosis, the severe mood dysregulation. So we're just starting to get research using the DSM-5 criteria. And so diagnose this and look at this with caution. The one thing I encourage you to take away from this, if you take away nothing else, is that DMDD is not pediatric bipolar disorder. It is not pediatric bipolar disorder. So some of the estimates I saw for child pediatric bipolar disorder, less than 2%. Yeah, it's exceptionally rare. And so because the diagnostic criteria for DMDD is not great, I've seen a variety of estimates, and I think part of that is due to some of the psychometric stuff I was talking about, that they're not reliably identifying it, and they haven't identified it in a way that's stable over time. But the estimates have ranged from 2 to 10%. I'm very skeptical of 10%. I don't think that's probably very likely. But that it is more prevalent than pediatric bipolar disorder is believable to me and seems to be consistent in the literature. Yeah. Mm-hmm. Yeah. Well, and I think it was, I mean, one way to look at it is it was an excuse to use neuroleptics. But I also think that part of it was, I think there was this just legitimate thought that just developmentally it's going to look different, that bipolar disorder looks different in kids. And these kids that are hard to manage, there has to be something, there has to be some explanation for why they're harder to manage. And we know how to treat adults that are hard to manage, right? We do all these drugs. And so I think, at least I want to believe that it was well-intended. Um, and I'm sure, at least for some people, it was. But, I think that it's, I think they're trying to correct that now, and I think that's why we're seeing this diagnosis. And part of what worries me personally is I don't think that this diagnosis is being used the way it's intended to be used. I think that despite significant efforts to distinguish this from pediatric bipolar, people are using this to capture kids they previously captured as pediatric bipolar, and they're considering them the same way. It hasn't changed how they think about these kids. And I really encourage you to think about these kids differently. These kids that are chronically irritable are not bipolar, and they're not going to benefit necessarily from, they don't need the bipolar treatments in order to benefit. One of the things, the Journal for Adolescent and Child Psychiatry came out with some treatment recommendations. So they looked at what evidence was out there, and they were trying to help psychiatrists understand how to treat this new disorder that we have. And my wording is a good bet, safest bet, but they said there's evidence to suggest that these kids respond to stimulant medication, and that these kids respond to behavior management and parent training. And that there's really, I think that if you think about bipolar disorder, you think about this organic disorder that's completely outside of the child's control, and it's going to be really tough for them to learn any way to manage this. In the same way we would look at childhood schizophrenia, we're not necessarily going to go in there and start with coping skills. We're going to start with medications. And what they're saying is, no, we have some evidence that these kids, even though they have a very severe presentation and a very problematic presentation, they're responding to some of our first-line psychiatric treatments with stimulant medication, and they're responding to some of the first-line treatments that we recommend, which is behavior management, training parents how to better respond to these behaviors and teaching parents how to teach their kids how to behave in different situations. And so that's a good bet. Although the evidence on the stimulant medication, there haven't been RCTs doing DMDD and randomized clinical trials, and so it's not really strong evidence there. But there are several different studies looking at it, so it's a good bet. The safest bet, though, is behavior parent training, and I say it's the safest bet because there aren't side effects from behavioral parent training. A kid is not going to gain 40 pounds, because, well, if you're good. He's not going to, unless you tell the parent to feed him constantly, not going to gain 40 pounds from behavior parent training, right? The kid's not going to die of a lethal overdose of a medication, right? The behavioral parent training is a good, safe bet for a first-line treatment, and we have some evidence to suggest that these kids, even though they have a very severe presentation, would benefit from this. And I think one of the frustrations is kids with pediatric bipolar, they're not going to benefit. They'll benefit some, absolutely, from behavioral parent training. But if they're in a manic episode, there's not going to be a lot you can do. But these kids aren't pediatric bipolar. So try the behavioral parent training first and use that as a recommendation. And if somebody comes in and says, oh, this kid has DMDD, we can't do anything with him, challenge that. Say, no, I think we can try some things. I think there's some things that might be effective for this family. It might be hard. It might be difficult. They have a more severe presentation, but we have evidence to suggest that these traditional treatments that we're using for kids who have behavior problems will work with these kids with severe behavior problems and severe mood problems and severe chronic irritability. It may not make them less irritable, but it will reduce the temper tantrums and the outbursts that they're experiencing. So, oh, sorry. So I haven't seen any of that, and I've been trying to stay on top of it. It's good. I think that's a really important one, but DSM-5 came out 2013, 14. So, I mean, if you think about how large scale those studies are to look at the prevalence rates of things, hopefully that's happening now. And I know that there are a number of researchers out there looking at those types of things. My hope would be, yes, that it's decreased that rate, but I also know that a lot of times providers are slow to adopt new diagnostic manuals. So it may take time for this information to get out there as well. Mm-hmm. Yeah. 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 Yeah, and I think sometimes it's used that way. I think that sometimes they go, well, yeah, this kid has behavior problems, but ODD doesn't really, it's not strong enough, right? And if a kid has ODD, there's not a medication for ODD, right? And so it then becomes hard to justify treating them with medication. And so this diagnosis is given because you can justify medication for this. And, you know, I think that's problematic in some ways when it's not accurate, and it's even more problematic when the jump, once they're given the DMD diagnosis, is to go to the antipsychotic and the mood stabilizer medications. You know, personally, it's less concerning to me if they try them on a stimulant when they give them this medication, because there's not a huge risk to that medication. Yeah. Mm-hmm. Yep. Well, and I think that one becomes a really tough one to untangle, although I think you absolutely have a point, but how often are they born drug exposed, but then exposed to a number of adverse experiences early on, and so how much of it was just their in utero brain development versus how much was it after they were born and the environment they were exposed to? Mm-hmm. Yeah. Right, potentially. Yeah. Yeah. Right. Yeah. And I think one of the reasons, you know, oftentimes when they go with some of these age cutoffs, it's arbitrary. I mean, you know, with ADHD, it moved up, but not really guided by anything other than that they thought it was too young to begin with. But I think that part of the reason that this cutoff was at 6 was they didn't want people overdiagnosing this in really young children, because there is a developmentally appropriate level of temper tantrum that I could definitely see that concern, that if you allow this to be diagnosed in 2- and 3-year-olds, every parent who's stressed out is going to say their kid has DMDD, right? And yeah, and Risperdal, you know, why not? Yeah. 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 Well, and you know, I mean, some of those risk factors for DMDD are also risk factors for depression, right? In the same way. Yeah. Yeah, you know, I mean, we don't necessarily talk about environmental risk factors for bipolar in the same way we talk about environmental risk factors for this, because bipolar we know has a large genetic component. And the fact that we're talking about environmental risk factors, it's something different. And yeah, I could absolutely be convinced that this is a different presentation of childhood depression, right? In the same way I could be convinced it's a different presentation of ODD. But I think the one thing I am thoroughly convinced is it's not a childhood presentation of bipolar disorder, not bipolar disorder. We're really good at identifying that there is a problem, but we don't know why the problem's there. Yeah. Yeah. Well, and I think it brings up the other argument of trying to go with potentially least harmful, most appropriate diagnosis, right? And I think part of the problem with this diagnosis is I think it is less harmful than pediatric bipolar, like absolutely. But I also think that the education isn't out there for some of the treatment providers to understand that this isn't pediatric bipolar. So as a clinician, you may be very well intentioned in giving this diagnosis, saying, well, I'm not going to give pediatric bipolar, that doesn't fit, that's ridiculous. But then another provider comes along and sees DMDD and says, oh, yeah, I treat that the same way I treat bipolar. You go, wait, you've just lost it. Right? Wait, are you seasoned? Yeah. Yeah. Well, and I think that hopefully the goal is to get some of the medication providers to understand this difference and getting them to read some of these articles in their journals put out by their professions suggesting that go slow, start with stimulant medications, start with SSRIs, start with some of these less risky medications, and work your way up. And you may need to get to some of those things to address some of the symptoms. And, you know, the jury's still out on whether or not those bipolar medications are helpful for this. Some of those medications are pretty strong. I imagine that they would make anybody less aggressive. But, I think that it's go slow and, be safe along these lines. And you can pretty well guarantee you're being safe with behavioral parent training. And you can pretty well, they can pretty well be sure they're being safe with the stimulant medications with these kids. But they don't necessarily know that. And I have all of these articles and citations. If you have somebody you're having trouble convincing, not that this always works to convince anybody, but I'm happy to send you the articles and you can share them with whoever because there is stuff out there, and it's, by people who know more than me. So, and then the last thing, they are always looking for these kids to do studies. And so if you have a kid who you're like, okay, to a T fits this and I'm having a hard time with it, there's usually ongoing recruitment. So if you have a kid who actually has pediatric bipolar disorder, there's the first one, Bipolar Kids. If you have a kid who you feel like meets the DMDD criteria, you have that one. They tend to, I don't know that they necessarily recruit in this area, but depending on parents' ability to travel and, reach out to them. If you have several kids, email them to see if they're recruiting here. But the more we can get this research going, the better information we're going to have to make decisions. So, yeah. All right. Thanks.